First of all, that this domain exists. I think that is maybe neglected too much, and real in-depth immunology is even not foreseen in the educational program for oncologists, although one should realize that tumors grow in a body and that the natural defense of the body is done over the immunology, over the immune system. So neglecting this tool is already a major issue and should be trained much more. Further, I think, and that's a little bit based on the experience that I have in the last years, the term immunotherapy is in fact a little bit misused, and most oncologists refer to the use of checkpoint inhibitors as immunotherapy. But there are much more modalities of immunotherapy than just checkpoint inhibitors. Checkpoint inhibitors belong to what we call modulatory immunotherapy. That means you facilitate an existing anti-cancer immune response so that it really controls the tumor. For instance, in melanoma, in lung cancer of smokers, there you can assume, as these tumors are at the outside of the body and are irritated, that you have already an anti-cancer immune response, and the tumor uses the checkpoints to escape the immune system. So if you come then in with your checkpoint inhibitors as modulatory immunotherapy, you block blocking mechanisms and you de-block the immune system that it is effectively controlling the cancer. But that's only one type of immunotherapy, modulatory immunotherapy. There are, of course, other types of immunotherapy that should also be somewhere recognized. Monoclonal antibody therapy as passive immunotherapy. In some domains it exists. For instance, Herceptin in breast cancer or in some colorectal cancers. That's well known. Passive immunotherapy with antibodies. Adoptive immunotherapies with cell-based therapies, T cells, NK cells. Then we come, for instance, in the domain of tumor-infiltrating lymphocytes used in melanoma. The whole world of CAR T cells, that all belongs to adoptive immunotherapy. Then you have the immunogenic cell death immunotherapy, ICD therapy, that is in fact all the technologies that try to kill cancer cells, thereby inducing an immune response against the cancer. And again, there is a lot of possibilities that you can use. It's now well known that radiotherapy, if you give it in particular technologies, can induce immunogenic cell death and immunize the patient against the cancer. Some chemotherapies, like doxorubicin, are known to induce ICD. Tumor treating fields, so these electromagnetic waves, were supposed to induce cell cycle arrest, but in fact also induce immunogenic cell death. Oncolytic viruses, a domain that is coming up very, very, very much, is in fact a mechanism of immunogenic cell death. Modulated electrohyperthermia, as in some centers provided, they induce in fact immunogenic cell death. So we have not only modulatory immunotherapy, passive immunotherapy, adoptive immunotherapy, immunogenic cell death immunotherapy, but we have also active specific immunotherapy. That's then the whole domain of the vaccines, where you try to stimulate immune cells to fight against a target in the body, against tumor antigen. So immunotherapy, first of all, the immune system, the oncologist should be aware that this exists. And the term immunotherapy should in fact include all the possible technologies, all the possible strategies, all the possible goals that you can reach if you start playing with the immune system against the cancer. Well, we have our immunogenic cell death immunotherapy, and within the immunogenic cell death immunotherapy, we have the use of oncolytic viruses. Here we have the Newcastle disease virus, of which it is shown that it induces immunogenic cell death. We have also the modulated electrohyperthermia. These are electromagnetic waves that give a heat stress and thereby also induce an immunogenic cell death immunotherapy. So we have immunogenic cell death immunotherapy in-house. We, of course, can buy antibodies in the pharmacy and give passive immunotherapy. As an example, Herceptin can be bought in the pharmacy and we can give this passive immunotherapy. Of course, our major topic, that was also the first type of immunotherapy that was particularly introduced here, are the active specific immunotherapy as third modality of immunotherapy. There we have our dendritic cell vaccines to stimulate immune cells against the cancer. But meanwhile, we have also long peptide vaccines. Eventually, we can load short peptide on the dendritic cell vaccine. And we are also moving now forward to lysate boost vaccine. If we get tumor material from the patient, we use the tumor proteins as lysate to load on the dendritic cells. But we can also use this tissue later on as lysate boost vaccines, because it has been published, at least for some tumors, that the induction of the immune system with dendritic cells, but then the maintenance of the immune response is then better with lysate vaccines. So we also try to implement now lysate boost vaccines. So we have immunogenic cell death immunotherapy in-house, we have active specific immunotherapy in-house, the modulatory immunotherapy we have also in-house. Of course, the checkpoint inhibitors we can buy in the pharmacy. And there it might be important to mention that the different checkpoints, having their different activities, can be used at different time points in the therapy to reach particular goals. So the checkpoints that we use during vaccination will be different as compared to the checkpoints that we use after the vaccination to maintain the immune response. So everything should be placed somewhere in a global strategic plan. And in each phase of the therapy, you need to define your goals and you need to use your weapons to reach that particular goal. Within the modulatory immunotherapy, there is more than only the checkpoint inhibitors. We believe that the anti-inflammation therapy is also a very important element in the immune modulation activity that you want to reach. And there you have the curcumins, you have the antihistamine receptor 1 blockers, you have the COX-2 inhibitors. These are all drugs that patients can buy in the pharmacy, but that have all somewhere their place as anti-inflammation, being a component of the immunomodulatory therapy. So quite a lot. That's in fact a quite complex question. So, very simply said, a vaccine consists of three elements. There is the antigen, there is the vehicle to bring the antigen in the body, and there is the danger signal to elicit the immune awareness and the immune activation. So let's focus on the antigen. If we have tumor material available, we can use it for making the vaccine. And this use for making the vaccine can be in several methodologies. People like Sigat and Maineo in Ghent, Sigat in Tübingen, they use the tumor tissue and they compare the genetic elements in the tumor tissue with blood. And they see what is the difference. And then a computer can predict what could be then the specific tumor protein elements that are tumor antigens in the tumor compared to the healthy blood. So they come then with computer-predicted tumor-specific neoantigens that the computer predicts that's on the tumor. These antigens can then be produced in laboratories that are called peptide vaccines, and that's then the peptide vaccine that is specific, as predicted by the computer, for the tumor. So that's what could be one element to use the tumor as tissue to predict the tumor antigens. Others, like I have done in my whole career, so to say, I have used the tumor as source of tumor antigen. So what I simply did was I make a sort of mixture of this tumor, then the proteins are there. The tumor antigens are certainly in it because it's a big mixture. And I use this mixture to load my dendritic cell with this mixture. And then the dendritic cell has to decide which pieces of proteins will be presented on the MHC molecules of the dendritic cell. So that could be another way to use the tumor tissue as source of tumor antigens. It happens, however, in a lot of cases that we do not have this tumor tissue available in the way as we usually do it. And of course, if you have tumor tissue available, but you have also a metastasis on distance that you have not available, you might assume that this metastasis on distance, living in another environment, another organ, might have a little bit a different biology, might have a little bit other antigens. So to solve this problem, we have created the methodology that we can induce what we call immunogenic cell death with oncolytic viruses, with electromagnetic waves, our modulated electrohyperthermia, so that we break down in the body the antigens or the tumor, and that the antigens are released in the blood. And then we can take this blood to get out the antigens for using in our vaccine. So that's another methodology to get the antigens. And then we do not need the tissue anymore in our hand because the tissue is in the body. And we kill the tissue in the body to get the antigens out for our vaccine. The advantage of that is that we have the most actual tumor antigens that are present at time of the production of the vaccine, and that becomes more and more important when the tumor is a highly dynamic process and changes each week or each month, because then you have the actualized tumor antigens and not predicted antigens from the past. And you have the antigens that might differ in different places in the body, metastasis versus primary tumor. And there, the technology is coming up. We do that already for years, but now we are starting really to learn how that works. We call these types of antigens extracellular microvesicles. Another term is large oncosomes, apoptotic bodies, and this can be yielded out of the blood after the modulated electrohyperthermia and after the treatment with oncolytic viruses, and are the most recent everything overarching antigens that can be used in the vaccine. So that's all for the vaccine. The second element is the carrier. I've already referred. We load our antigens on dendritic cells that we create out of the culture of the blood of the patient in the laboratory. others that do not have the approval to create dendritic cells out of patients, because you need for that an approval, they can only use sodium chloride. And then the danger signal, this is an extreme important component of the three elements of the vaccine antigen vehicle danger signal. There, the ones who do not have the dendritic cells, they have to inject some product, for instance, GM-CSF. They prepare the skin with a cream, Aldara cream. We, however, when we have our dendritic cells loaded with the antigens in the laboratory, we can give a massive danger signal in the laboratory, because there it's not dangerous for the patient. And then we have highly alarmed, activated dendritic cells that we inject back into the body. That are the whole issue of antigens and vaccines. It's a very complex world. There are many variations, and it needs the real expertise to create your vaccine in an appropriate way so that you do not harm your patient, but that your patient gets benefit out of it. What are the side effects of immunotherapy? As I have already said, there are different types of immunotherapy. I've said you have the passive immunotherapy, adoptive immunotherapy, immunogenic cell-death immunotherapy, active specific immunotherapy, and modulatory immunotherapy. Each have different technologies, each have different methodologies, each have different goals. So in fact, we have to split this question into the different modes. So if we look to the passive immunotherapy with antibodies, it can happen that the patient reacts against the antibody and against the different components in the antibody. Sometimes you have to give an antihistamine before, some give some steroids before to block down the anti-passive immunotherapy immune response, so to say, so the immune response against the antibody. That's mostly an acute reaction. Some antibodies can also have some more long-term side effects. For instance, the Herceptin for cardiac function has been correlated, so that should be monitored, and mostly these side effects are present and are presented in the prescriptions that the companies give, and they sample all the toxicities that are registered. With the adoptive immunotherapy, so the T cells, I think the tumor-infiltrating lymphocytes, they do not have that much side effects, but once it comes to CAR T cells, then you have much more side effects, because these CAR T cells can induce what they call a cytokine release syndrome. So the patient can become acutely, severely ill, and then this cytokine release syndrome giving a lot of inflammation, a lot of alarm, it's a sort of mini explosion in the body that should be handled. Sometimes intensive care unit is needed. Mostly they can handle that, but so you cannot do that in a praxis. You need a really hospital with an intensive care unit, if that would happen, that it is handled in the appropriate way. In the CAR T cell world, sometimes you have a neurotoxicity image, which is not completely understood, but it can happen. In other T cell therapies, the toxicity is much less. Also, in NK cell therapy, another type of adoptive immunotherapy, toxicities are much less. So that's for the adoptive immunotherapy. The immunogenic cell-death immunotherapy, with the modulated electrohyperthermia, with tumor-treating fields, with oncolytic viruses, toxicities are quite minimal. You can have with oncolytic viruses some acute flu-like reaction, of course, but that's quite manageable over time. So there, I think the toxicities are less important. Of course, if you induce with your radiotherapy immunogenic cell death, or if you induce with your chemotherapy immunogenic cell death, then you have your known toxicities of the radiotherapy and the chemotherapy. With the active specific immunotherapies with vaccines, Usually the toxicities are very low. Rarely you see autoimmune reactions, very rarely, and certainly in the brain issues, it's not toxic at all, dendritic cell vaccines. So that is because it is called active specific immunotherapy, so it is specific against the antigen. So the toxicity is not general because it's a specific therapy. That stays in contrast to the toxicities of the modulatory immunotherapy, the checkpoint inhibitors. For instance, there, as I have explained, you facilitate an existing immune response. And of course, if the cancer or the body in their immune regulations block some immune responses over this mechanism of checkpoints, and if you then block the blocking mechanisms, then the immune system does its job, but can also do its job where it is not wanted anymore. So you can have some immune response against intestines, you can have some immune response against skin, you can have some immune responses against your articulations, you can have immune responses against your thyroid function. So if the body was able to regulate the system over the checkpoint inhibitors and you block that, you will feel that in autoimmune reactions. And then again, you have to bring that down with steroids. That's manageable, and there are standard operating procedures and publications how you have to do that. But for the patient at that time point, it can be quite an issue. The advice is communication. As I have already said, the domain of oncology is completely different as the domain of immunology. I strongly regret that the oncologists are not trained in in-depth immunology and immunotherapy. So the only way to overcome that in a dosed way is communication patient per patient. If the patient is interested in immunotherapy and we design an individualized immunotherapy plan, I would love to explain this individualized immunotherapy plan to the oncologist. It's impossible that the oncologist can have that experience that we have. It's also not a shame. It's only an invitation. Communicate for the care of the patient. And from our side, we are always open. There are emails, there is Zoom nowadays. After the COVID, we have communication methods as never before. Let us use that, patient per patient, to communicate together what is the plan of the care that the oncologists want to give, what is the plan of the immunotherapy, tumor microenvironment treatment that we are working on, and then we have the global care covered for this patient. Simple is, it's very simple. We need a global strategic plan for each patient. It's the war against cancer. So we need a global strategic plan, and there are different weapons that we have to use at different time points, each time point having an own separate goal. We have developed the idea that we need a multi-phase plan. So you never win the war with one battle. You need several battles with several goals at several time points. So in our global strategic plan, we always start with an anti-cancer phase because the cancer must be away as much as possible. So the anti-cancer phase is the most important. And there we have the surgery technologies, we have the radiotherapies, we have the chemotherapies. That is the leading element in the anti-cancer phase. Sometimes not enough. So we believe that we can strengthen the anti-cancer phase with different types of immunotherapies, like the immunogenic cell death immunotherapy, or the anti-inflammation immunotherapy, tumor microenvironment treatment to get the tumor milieu already more prone for the chemotherapy, but not only for the chemotherapy, also for the immunotherapy afterwards, eventually. So we can easily combine immunogenic cell death immunotherapy with the classical oncologic anti-cancer treatment modalities, the surgery, the radiotherapy, the chemotherapy, but also targeted therapies in some cases. Combine that with immunogenic cell death immunotherapy with the aim to kill cancer cells, to change the tumor microenvironment and start some smelling of the immune system. And then this anti-cancer phase is finished, but then the job is not finished. Then you have to immunize. You have to build up the immune system against the residual cancers, the cancers that you have not killed with your anti-cancer phase, the ones who are left. You have to go to each corner in the body with your immune system. That's the job of the immune system. So then you have to immunize with your vaccine technologies, and you have to facilitate with the modulatory immunotherapy technologies to clean everything as much as possible. But then it's not finished. The cancer will try to escape the immune control. The cancer immune escape mechanism, that's a scientific term. So in order to prevent the new initiatives of the cancer or to counteract at an early stage the new initiatives of the cancer, you have to maintain your immune system active against the cancer. And that we do here with the immunogenic cell death immunotherapy. So cell death, you kill cancer cells. Immunogenic cell death, you immunize against these new initiatives. And the immune system might become tired. So you have to facilitate a little bit this maintenance phase, and that's where we again come in with low-dose modulatory immunotherapies, with low-dose checkpoint inhibitors to counteract the exhaustion of the immune system on the longer run. So that is in fact the global strategic plan where the immunotherapy is completely integrated within and after the standard of care, standard oncology treatments. And I sometimes compare it in a very simple way. That's in fact also the summary of my personal professional career. I say the tumor can block the immune system, certainly the glioblastoma. So first phase is reduce the tumor. Second phase is stimulate the immune system. Now the immune system can block the tumor. And the third phase is the cancer will try to escape. So in the third phase, we have to border, canalize the tumor initiatives. And that is, I think, a very valid global strategic plan that is also very realistic, and that is here daily activity. I've said we have different modes of immunotherapies. We have the passive immunotherapy, adoptive immunotherapy, immunogenic cell death immunotherapy, active specific immunotherapy, modulatory immunotherapy. This one, the adoptive immunotherapy, I think there in our setting that we have here, because one should be realistic in the setting that we have, we might have a potential strategy because we know, certainly in brain cancer, that some viruses elicit or trigger the cancer. They are not maybe the driving factor, but might still be the triggering factor. And one particular virus has come into the eyes. That's the cytomegalovirus, CMV. Is a common infection in children. And CMV might somewhere in some patients be a triggering factor for brain cancer. Might. And there there are several people working on that. For instance, in Karolinska Institute, they have done trials with valganciclovir, which is a drug against CMV. In Duke University, they make vaccines against CMV to treat brain cancer. And we are developing here an adoptive immunotherapy with immune cells, T cells, that we expand if they are specific for CMV. We expand them in the laboratory, and we hope that we can use these immune cells as direct soldiers to fight against the CMV. As we have said, the tumor is a microenvironment that is immune suppressed. You can assume that CMV, if it is in the body, that it will be there expressed. So our CMV-specific soldiers will directly move to the tumor and kill all what has to do with CMV, the tumor cells. So that would be a novel approach that I dream to get realized, and we have done a lot of preparative work, and the documents should be sent to the authorities, because this is again an advanced therapy medicinal product that should be approved by the authorities to be able to produce that and to give that to patients. Another element that I think is extremely exciting at the moment, and we are even trying to set up a European project on that, is these antigens. As you know, we produce antigens mostly by killing the cells, the cancer cells in the body, with the oncolytic virus and with the modulated electrohyperthermia. So if you kill these cancer cells, you can say these antigens fall in the blood, and we use this blood to load our dendritic cells in the laboratory. So these are highly tumor-specific antigens, and we now can use the term the secretome. So cells secrete elements in the fluid, in the blood. And this secretome, there our antigenic extracellular microvesicles are in it, and our large oncosomes are in it. And with a team of partners, universities, large enterprises, small and medium enterprises, we have now set up a collaborative effort in a European project in the Horizon calls to characterize and quantify this secretome better, that we can follow over time what is happening. Because if we can follow the dynamics of the tumor by analyzing the secretome of the tumor, I think then we will learn a lot more about tumor biology and how therapies influence in the tumor biology. So besides my CMV T cells, I dream about the analysis of the secretome, and there I'm very lucky that a lot of universities and other teams are willing to help on that. He and other investigators have really done a wonderful, extremely wonderful job in the last 10 years, I would say. So the change from the pathology in the diagnosis of brain cancers towards pathology plus molecular biology, that has really created neuro-oncology coming into a new world. Simple like that. So the first major step was, in fact, the classification systems and the computer machine learning, where they have analyzed tumors on the epigenetic expressions, and where they can make maps where each tumor point is somewhere located, clustering them into the different diagnoses. And now the accuracy and correctness of the diagnosis of brain cancer is becoming extreme. And I think the Heidelberg classifying system is now worldwide used, and everybody brings tumors together, learn from the whole population of tumor, and can characterize the single patient that they have within this whole community. So that is not sayable how important that is for the patients. But people have gone steps further. With these modern molecular biology technologies, as far as I understand it, because I'm a neuro-oncologist, immunologist, but not molecular biologist, so it's again a new world appearing, but I'm very interested in the new world. They apparently can make this diagnosis within half an hour, 2 hours max. They already can classify the tumors within the operation. And that will change the world again completely, because the neurosurgeon, having a lot of stress to get a safe operation, he will now become informed about the exact name of the enemy while he is there. And that means for some tumors, the neurosurgeon can start making the strategic plan of the operation. Some tumors, it's prognostic very important that it is completely or as completely as possible resected. Then the neurosurgeon knows this enemy, I have to do maximal neurosurgery and go to the risks of the border. While other tumors, if the neurosurgeon knows that's an enemy, and there is also a lot of other treatment modalities in the anti-cancer phase that can be used to ultimately kill the enemy, then the neurosurgeon can do a tumor volume reduction, a reduction of symptoms of the patient, but in a much more safe way, because he can rely on the other treatment modalities to do the ultimate job. So I think in the strategic plan for the neurosurgeon, already thinking about the global strategic plan, these novel diagnostics are really opening a new world. Imagine you know your enemy while you are facing your enemy. That's something what earlier was not possible. Earlier it was difficult to make your diagnosis on the pathology, and pathologists were really trying to get it realized with reference pathology and so on. But now with the addition of this molecular biology, pathology remains extremely important. But the much more knowledge what is occurring, and that during operation, it's incredible. It's really incredible. And how that will go in future, we will have need to adapt our whole treatment strategies. Now it might become even important to do before the operation. So if you have only a needle, you do your diagnostics. It might be that other treatment modalities will become more important before you do your resection at the end. So it will change. It's incredible, and a lot of work is standing in front of us to get that all realized, and it will certainly be of benefit of the patients. Well, the story of Kevin. What should I tell about the story of Kevin? I think this is really an example of the power of the immune system. And as far as I understood, because I did not read really scientific elements about this particular case, but what has been reported in the press, I was so happy that it was reported, because it gives hope for patients that with the immune system you really can tackle the impossible. And I think here it was a very difficult tumor, And with the smart approaches that the medical team there has realized, using the immune system with these checkpoint inhibitors, they apparently got this big success for this patient. And they have illustrated that the impossible can become possible if you want to do it. And that is, I think, the big message behind. Never give up, but remain looking. And what I understood from this is that it is an example that with the modulatory immunotherapy, with the checkpoint inhibitors, you really can use what the tumor has used to grow. The tumor has used to grow a blocking mechanism to block the anti-cancer immune attack. So if you can block the blocking mechanism, the immune attack will occur and your patient will have benefit. And that is what here is a very nice example. And it is very important that a lot of people are informed about such possibilities so that also in their own case, one should consider these immunotherapeutic modalities.